today we have one of our own, Dr. John
Couldn't find
Waterbor.
anyone else, could you?
Yeah, who doesn't need any introduction.
Don't.
He's an associate professor, but he retired, but doesn't look like he's retired because he's always in campus, always willing to teach, always
There's the
willing to present.
phrase, forgotten but not gone.
Yes, and always willing to help students. So he's going to talk about cancer epidemiology and control. Of note, he was fortunate enough to work with Dr. Phil Cole. For those of you who don't know him, he was a very well-known cancer epidemiologist here in School of Public Health. So with that, Dr. Waterbor, welcome to the Epi-Seminar.
Thank you, Dr. Shrestha, and thanks everyone for coming. Please grab a slice or two of nature's perfect food, the pizza, if you are hungry. See a few former students in the back. I'm going to talk about cancer epi and control. I have within this presentation some basic epi concepts review, figuring there might be new students, and maybe there will be, or people who are not epi majors, so forgive me if I go over a few things along the way. One of my former teachers used to say, if we can define our terms and agree what they mean, then we can talk about anything, from baking a chocolate cake to building a nuclear bomb. Now, I don't know about the latter, but anyway. So as Deep mentioned, my training has mainly been in cancer epidemiology, cancer control. What's the difference? I'm texty in my slides, but that's the way I am. So slides are crowded. You have access to my slides forever and ever if you want them. So I'm not going to read every word, but I'll kind of skip read them. And actually I have 3 presentations back to back to back. So it may go on to about 3:30. Okay. Epidemiology, as Dr. Beth Lewis will tell you, chair of epidemiology, the epi is the fundamental science of public health. And epidemiologists, again, for the benefit of people who are not epi majors or epi was not their passion, epidemiology is the fundamental science. We look for causes of diseases. And the idea there is at least some of the causes we later learn can be prevented, like smoking cigarettes. Once we learn that's a major cause or the major cause of lung cancer, that's something that can be dealt with by health behavior, health policy, and so forth. Cancer control is the extent of publications I have. I'm not a great publisher of papers, probably too late now. Cancer control is the application of epidemiology to make favorable changes in the community. So cancer control, the idea is to reduce incidence, the occurrence of new cases. For those cases that were not prevented, diagnose them early. And number 3, for those cases diagnosed, whether early or late, to facilitate their treatment, access to treatment, high quality treatment, and so forth. Okay, perspective on cancer mortality. Epidemiologists like to talk about death, so I will here. So 2024 statistics, and I like the top 10, used to be on David Letterman, I think, like the top 10 of everything that you want to talk about. Leading causes of death, 2024 National Center for Health Statistics. I like to think of the 10 in kind of 3 tiers or sections. The 2 major causes of death are heart disease, this is in the United States, heart disease, or you could say heart diseases, and cancer or cancers. So you can see by the numbers there, 683,000, 612,000. That's kind of like or section number 1. Numbers 3, 4, 5, 6, 7, unintentional injury, otherwise known as accidents. That's mainly for death. It's mainly drug abuse and motor vehicle crashes. Unintentional injury, stroke, chronic lower respiratory diseases, Alzheimer's, and diabetes. They're all in the, if you look at the numbers, all in the 100,000 to 200,000 range. So they're kind of layer number 2. And the last 3 that make the list, kidney diseases, chronic liver disease and cirrhosis, and suicide. And as an aside, a lot of people are surprised that suicide ranks higher on the list in the United States than does homicide. Homicide, it's off the list, it's like number 12, number 13, so maybe they're close. Okay, very texty. For those people who forgot the REPI methods, I present to you, again, perspective of where cancer fits. Heart disease, the numerical figures are about the same as on the last slide, not quite. So you see three numbers, for instance, well, let's go to the cancer in yellow. So cancer 619894, if you look at these slides later, that's the actual number of deaths or death certificates, you could say. Pile them up, be a big pile, 620,000 death certificates. 185 is the mortality rate, and as you remember in epidemiology, a rate has time as a denominator. So the mortality rate is 185 per 100,000. So how we got that calculation, as we took 619,894 deaths, and what was the population? The population size, about 335 million. So if you do the math and then do by algebra per 100,000, it comes out to 185. The 20% for cancer, new denominator, that's of all the people who died in 2024, what percent died from cancer, and the answer is 20%, okay? So you can see where cancer fits there. A pearl, this is something I sometimes like to impress people, just people I meet. So this, you could use this, now put this in your pocket. Maybe you're in an elevator somewhere or just met someone, and you can say, did you know that in the United States each year, about 1% of the population dies? That kind of heavy? Okay. In industrialized nations, that's about correct. And if you do the math, you could show that below. Okay, when people die from cancer, what kind of cancer do they die from? They're the major cancers that end up being cause of death. You can see lung, heads up both lists, although I think lung cancer is being controlled better. Fewer people are smoking, and there's now a lung cancer screening test. And you can read the rest. These are the major players. Cancer is a genetic disease. Yeah, I mean, I'm trained more as an environmental cancer epidemiologist. I don't have a degree in genetics, but I know some people who do, and Sudeep knows a lot of genetics. The idea in epidemiology, if you were kind of a traditional cancer epidemiologist, is to look for contributing causes that are environmental. By environmental, we mean everything that isn't genetic. So environmental would be smoking cigarettes, drinking alcohol, not exercising, certain occupational exposures, radiation, so on and so forth. So that's the easier, well, easier, I don't know if it's easier on a practical basis. The reason we see, or friends that I have who do genetic epidemiology, says cancer is a genetic disease. That gets back to the idea of multifactorial causation. That is, if you wanted to give yourself lung cancer for whatever tortured reason you had, could you guarantee you got lung cancer if you smoked a whole bunch of cigarettes for a long time? The answer is no. Yeah, Mr. Spock of Star Trek would then say, logically speaking, Captain and others, there must be a second factor why you heavy smokers got lung cancer and you heavy smokers never did. So that suggests kind of the so-called multifactorial theory of causation, that components have to come together to produce a case of lung cancer. As an aside, does anyone here bake pies or cakes or anything?
What was the question?
Do you bake?
Some things. Yes.
You do, okay. So this is coming up an analogy.
Okay.
So the dean bakes, that's good. Can you tell me, since you have baked, how do you bake a pound cake?
I asked my wife. I asked my, she is the queen of pound cakes, and bake it in the oven for 350 degrees for an hour.
You're playing right into my hands.
All right, good.
Does anyone know why a pound cake is called a pound cake?
Pound of of everything.
And
Pound of flour,
pound of flour, pound of butter, pound of sugar. The next one nobody gets unless you already heard it.
causes you to
Got
get
a lot of
diabetes.
eggs.
A pound of eggs.
Yes.
Okay. So, my late mother, she lived a long life and a happy life because I was in her life. She called me once from her home in Pennsylvania, and she was laughing, and she said, I said, oh, it was like almost Christmas time. I said, oh, did you bake your famous pound cake? And she kind of laughed. And she said, I opened the oven, when the buzzer went off, and it was like a pile of crumbs. And she was laughing. And I said, well, what happened? She said, I forgot to add the eggs. So my analogy is, if the pound cake, as it should have come out, is a case of cancer, you don't get that product when you leave out one of the ingredients. So a pound cake is multifactorially dependent. You have to have the flour, the butter, the sugar, and the eggs. So if you remove any of those things, then you don't have a pound cake. You have something, but it's not that. So that gets into, again, sometimes thinking about if I wanted to give myself this or that disease, what guarantees are there? So there are environmental combinations of exposures and probably genetics that either allow or snuff out a would-be cancer to begin with. Okay. Reducing exposure, bullet number 2 in yellow, but often, other than you got a big radiation dose in an industry or something, a lot of the environmental causes of cancer are kind of the relatively low-grade ongoing exposures. So maybe in practical terms, not so easy to reduce. Childhood cancers, we'll talk a little bit about that at the end here, kind of a different ballgame. If we're talking about little kids, newborns and 1-year-old, they haven't been smoking, drinking, and doing other bad things environmentally, but they can get cancer. Okay. 5% of new cancers are among children. Good things if it's your child or children you know. Childhood cancer rates much lower in incidence, much lower in mortality, and much longer survival than adult cancers. A downside of childhood cancer, though, is the idea of late effects. So in our Children's of Alabama Hospital and other places that treat childhood cancer, children are often cured, or so it seems, as children, but they are advised to return annually or maybe more frequently to check out their health, because some childhood cancer treatments or radiation, chemotherapy, and it's creating maybe a disease that's going to happen in the future. So there are other late effects. Okay. Case fatality, as you remember from Epi, case fatality is characteristic of a particular disease. Here we're talking about cancer. That is, what is the probability you're going to die from a disease if you get it? Case fatality for the common cold is 0, because that doesn't kill people. If you get pneumonia after your cold, then we look for case fatality for pneumonia. These cancers have a high case fatality, meaning you often, we're talking about 60 or 70% of the time, you don't live long enough to die from something else. So the incident cancer becomes your cause of death. What do we do in cancer control? Again, the applied, once we know what we know about cancer causes, we don't know everything, but we know some things. What do we want to do? Well, in epi terms, we want to measure things. We're big on numbers and measurement. Incidence or occurrence of new cases, we would like over time to reduce the incidence rate. Mortality or deaths, we'd like to reduce that also. Increase survival, time of survival from diagnosis to eventual demise, and improve quality of life. These are all, if you have a career in cancer control, among these things that you would do are these 4. Okay, the ideal in public health, I think public health means, or an underline, is prevention. As opposed to treatment, I certainly, if I get cancer, I want treatment, graduates maybe from our medical school or elsewhere. But going back a step or two, I would like my cancer, if I ever have it, to be diagnosed early. And even better, another step or two back, I would like to have never gotten that cancer to begin with. So keep the healthy people healthy. That's the goal of public health. The example there. So if there are any, raise your hand if you're a perfect person. You're not. Here is, on one slide, what I could fit. Things to do or not to do if you want to avoid cancer. And if you fulfill all these, we'll give you a round of applause. I won't read them all to you, but tobacco use, again, in the U.S., and in countries where tobacco is not used much, it's not going to be number one on the list. Here it is. Reduce tobacco use. You can see the other dietary components, ultraviolet light, radon, radioactive gas in the earth, which is a decay product of radium, and radon in the U.S. is the second leading cause of lung cancer. So I don't have them with me, radon test kits, and if you later want one, you can email me. There's a radon test kit, kind of like a carbon monoxide tester. You open it up, you leave it in your basement or your first floor, and then you seal it up and you send it to the health department and it tells you your radon level. Ultraviolet light, and then again in yellow the right genes. So again, there are no guarantees here, which maybe is a good thing. Okay, again, many ways, for instance, to get lung cancer. There's tobacco, there's asbestos, there's radon, there's some other industrial exposures. That being said, when we think of what causes particular diseases, like you have 10 seconds on an elevator when someone asks you, what causes lung cancer? You could say, well, tobacco is the first thing I think of. So these are other first things you might think of. Obesity. I'm not sure I totally understand that. Tim Nagy and I used to talk about it. Tim was in nutrition sciences. The obesity-related cancers, they're now, I think, getting wise. Okay, so because it's a risk factor simply means we look at people who are obese versus people who are not, try to control for other differences, and then is there a difference in their cancer rates? So it is true, breast cancer, prostate cancer, colorectal cancer are higher among obese people. So obesity is now being measured in epi studies kind of historically, rather than put you on the scale and weigh you today and say, as of today, you're obese. That's maybe an indicator, but maybe the more important thing is if we have the data, what were you 2 years ago, 5 years ago, 10 years, 20 years ago? Is it the length of time you were obese? So that's something that's being looked at research-wise. Chemical particulate exposures and infections. Again, I've been at UAB so long and studied under also Dr. Herman Lehman, who, after whom, there's his plaque in the back. Dr. Lehman was a cancer epidemiologist and actually beginning was infectious disease epi. And Dr. Lehman taught infectious disease epi along with Dr. Mike Metz, Dr. Cole, and Dr. Dana Flanders, Dr. Harlan Austin, and later I taught chronic disease epi, cancer in particular. And we used to think of them, outdated now, like there's infectious diseases and there's chronic diseases, and that's like two different things. Now, of course, we know that some cancers can be a contributing cause, one of the component causes, can be an infection, hepatitis B, human papillomavirus, and so forth. A universal cause of cancer, if you're zapped enough in ionizing radiation, would be ionizing radiation. So we could cause, if we wanted to be nefarious, cause you to have cancer of almost anything by irradiating you enough. The obesity thing I always thought was interesting, and you can then rate yourself later, especially if you think you have a need. So again, this is not meant to criticize people and say to people, you're obese. We wouldn't really say that. Clinically, though, we might want to calculate body mass index, weight in kilograms over height per meters squared, one of those metric things. So the calculation, that's moi, me down here, 6 feet tall, 160. So I came out with a 22. So why do we calculate this? Well, again, in epidemiology, we like to know if we can characterize people in such a way that it gives insight into their risk of this or that disease. So again, there are several types of cancers where if you're in the obese category, your risk, if you don't already have, risk is a futuristic term, your risk is higher to get, say, breast cancer than someone with a lower BMI. Because our country, I guess it's cause and effect, more and more people seem to be heavyweight. In more recent time, there used to be just obese, and now there's obese class 1, class 2, class 3. So those who get an BMI high 30s or 40s, these are people, need to take some drastic action. Okay, so primary prevention is the ideal. That's the primary goal of cancer control. Find people who do not have cancer and advise them how to avoid getting cancer, whether it's behavioral change. The other way to do primary prevention is kind of brute force. So people in this room who are in healthcare policy, things such as banning smoking in restaurants, other policy decisions, and health behavior. That's all geared toward prevention and also toward secondary prevention, early detection. 3 approaches to secondary prevention. Prevention means you're not, if this is what your aim is, you're not preventing a new case. You are hopefully preventing an extreme or severe case or preventing death from that cancer. Okay? So one is very basic, but in Alabama we need health education. So again, I think the modern thinking maybe even goes back further, is start young. And maybe they do. There's always, when I was back in kindergarten a long time ago, I think I took health. The idea to make sure that people, whatever age, especially in pockets in Alabama, for instance, in small rural areas where maybe the education system is stressed, make sure to get the word across that people that maybe kids know that got cancer, there is some knowledge about the causes, and educate people again to do those things we said were healthy. And that's health education. Number 2, self-examination. It's hard to, and the idea of self-examination is, again, so-called secondary prevention, that I examine myself, my skin, for instance, or women do a breast self-exam, trying to find an early indicator of what could be cancer. Now, unless they're physicians themselves, they may not know what it is, but a breast lump, something on your skin that you never had before, have a significant other, relative look at my back. I'm going to examine my skin once a month or a couple times a year. Can't see back there too easily. Can't examine my colon too easily either. But self-examination for breast cancer detection, skin cancer detection, I think is certainly reasonable to do. Screening. So this is, in cancer control, the big push now, and screening is getting better and better and taking on more and more sites. So physical exam, that could be screening. An x-ray, another lab test. The key part of the definition on the test that you will get later is asymptomatic. Now, I would actually say acyanotic too. As an aside, signs and symptoms, the definitions that I'm familiar with are symptoms are subjective. So if I say I have a headache, I'm going home, Sadeep cannot verify, maybe he has some kind of contraption to put on my head. He can't verify that I have a headache or I feel tired. Versus a sign. A sign is objective. I have a rash here. He says, yep, you got a rash there. That's a sign. Okay. Back to screening. The idea of screening, if a woman comes in and says, I think I have a breast lump here, could you please screen me for breast cancer? The answer, without being frivolous, is no, ma'am, we cannot screen you for breast cancer. Screening is, you need a diagnosis. Screening, in my data set, these are women for breast cancer at high risk due to their weight, due to maybe just being female, being a certain age, and they know that they're at high risk, or maybe they have a family history. They have no signs or symptoms, and they are eligible, by definition of screening, to be screened. Someone who comes in with a lump or discharge or whatever would not be in my screening data set. They're in my diagnosis data set. Okay? So breast cancer, we can do all three. Educate about breast lumps, breast self-examination for women who want to do it. It's an art, I am told. I don't know how to do it, and maybe not have too much to examine it. But it's something that has to be taught. It's not just a quickly, feels okay to me. So I don't know if that's kind of in vogue or out of vogue. I'm not sure. For breast cancer, secondary prevention screening, the mammogram. X-rays, a very controlled dose. Excellent at finding early breast cancers. Okay, so screen detectable cancers. The NCI, National Cancer Institute, currently, unless they've updated something even more, now include 4, used to be only 3, cancers that they define or think about as screen detectable. Now, screen detectable, what does that mean? You can detect it on screening. But the second part of the definition is that there are data that say screen-detected cases live longer than symptom-diagnosed cases. That is, the theory is, why screen a lot of people for disease X if, in fact, if you got disease X, the treatment is easy, you're good, and you're cured. There's no reason to find it early unless there's a reason to find it early. The reason to find it early would be if you have data that say survival is much better. Now, you do have to correct for lead time, and so-called lead time bias. That is, if a woman's breast cancer is diagnosed 6 months earlier than she would have had symptoms, at least we could do the calculations, and then she dies on the same date as someone who had signs and did not come for screening, the survival may seem to be longer, but only because she got it diagnosed sooner. Does she live longer in this example? So you have to have data, which we do, that says breast cancer, mammography, we're good. We can recommend that widely, certain ages and so forth. Cervical cancer, as Sudeep and I were talking about, vaccine preventable. We can screen for it. We can do pap smears. We can look for HPV. Cervical cancer used to be high in Alabama. It's not in, if you go back slides, cancers that kill you, not close to the top 10 in this country. Although, as I mentioned to Sudeep, there are 37 countries, I read, around the world, mainly developing nations, where the leading cause of cancer mortality among women of that country is cervical cancer. So in this country, insofar as we have comparisons with the other cancers, we got it made here. We can vaccine prevent it, we can screen for it, we can treat it. And like it is now said, like in these modern times, no woman, in this country at least, no woman should die from cervical cancer. I just looked at Dr. Lehman's, Dr. Lehman aforementioned. I have his cancer booklets in print. Of course, there's no computers back. This is from the 70s, early 80s, where in the period 1950 to 1969, I don't know, that's kind of a long period, but more women in Alabama died from cervical cancer than died from breast cancer. And if you compare that to New York State, that wasn't true from back then. So things are different now. So breast cancer mammography, cervical cancer pap smear, colorectal. We have the digital rectal exam, colonoscopy, sigmoidoscopy, barium enema, fecal immunochemical test, fecal occult blood test. Now, are people going to get them? I think they're fairly acceptable. The newbie there of the 4 is CT scanning for lung cancers among long-term smokers. So in the past, fairly recently, it was said, well, we don't bother screening for lung cancer anymore because we do chest x-rays and they never show anything, and then that person gets lung cancer. So that's true. Chest x-rays doesn't do it. It used to be that when men or women, at least men, got a new job, and I don't know if it depended on whether they were smokers, but one of those, before we hire you or give you your employment physical, we do a chest x-ray. That turns out to be not very sensitive or specific, but now we have CAT scans, and the rules and guidelines are how often to do it and to whom, still developing. So there's the National Cancer Institute, there's the American Cancer Society, the American Academy of Family Practice. There's all these learned bodies that may differ a little bit on who do you screen and how often, age range, and for instance, if a woman gets 10 negative mammograms in 10 years in a row, do we want to keep mammogramming that woman? So these are things that are still in development, one learned body conversing with the other. Tertiary prevention. Okay, this is important everywhere, and especially in Alabama. Tertiary prevention means, okay, we got in front of us, we got a cancer case here. What do we do? So an important thing is access to treatment, access to any kind of treatment. Beyond that, access, ideally, to high levels, so-called state-of-the-art treatment. So if any of us in this room, or even after you graduate, if you have UAB behind you, and we have a great medical center and hospital, or me as an example, if I think I'm going to get cancer or I have it diagnosed, I have access, there's health insurance and stuff. That's the point. We would know where to go. There is a problem in Alabama. I used to study with Dr. Ed Partridge, who is head of our Comprehensive Cancer Center and is from Alabama, in a small town. I think it's Demopolis. The small town Alabama thing, that some people who live in small towns, I don't know if it's still this way or not, they have one doctor, there's only enough business to keep one doctor busy, and if they get cancer, they tend to go to the doctor who delivered them when they were a kid, if that doctor is still alive. But the getting to a specialist, there may be transportation issues, there may be bias issues of one sort or another, word of mouth. Okay. So what Dr. Partridge had set up, I don't know if it's still going on, is patient navigators that Dr. Partridge, being from Demopolis, Alabama, knowing small town Alabama, he and his people, when he was cancer center director, would go to small towns, identify who in town is the most respected person. Oh, so-and-so, this is the woman who runs the general store. So the person in a small town who would go to that person if you have any question about anything. They try to train them in pretty much patient navigation, what kinds of questions, health questions from people are important to deal with quickly. Okay. Excuse me. So tertiary prevention. Access is a big thing. Access to care, high-profile care, and our goals there are, again, to do the best we can once there's a diagnosis. We measure survival time, and quality of life, which is more difficult to measure, but it is now measured pretty well. Dr. Wendy DeMark-Wanafried, friend of mine in the Cancer Center, her example was she had a grant with master gardeners. So a master gardener is a certificated person with a certificate who's trained in plant physiology and soils and how to grow things without them dying off. Like if I plant tomato plants, they kind of die. So Wendy had a grant funded that breast cancer survivors, if they kind of needed something to do or wondering, I did survive my initial treatment, how long am I going to live? Should I give up on my life, whatever. At their option, they had access to a master gardener who would say, come with me, we'll meet in the classroom and we'll go to your where the garden is and we'll show you how to cultivate. And the idea, kind of, I'm not a psychologist, but the idea of new growth that you would see if you're successful gardening, the gardens where you were growing vegetables and so forth. That was one interesting area or example of tertiary prevention. Okay, genetic causes of adult cancers. What's my time here? The second and third, there's more slideshows, but we probably won't have time for them, but you'll have access to all three. The second and third slideshows are from American Cancer Society on numbers, rates, and trends. Okay. Genetic causes of adult cancers, yes, 5 to 10%. hereditary syndromes, unusual or rare. Genetic counselor, we have a genetic counseling program here at UAB, not in the School of Public Health. I guess it's School of Health Professions or School of Medicine, I'm not sure which. So one thing genetic counselors do is, with the idea, well, I guess a lot of their business would be mom and dad want to have a baby and there's a genetic tendency for some disease in mom's side or dad's side, and talking about should we have a baby or not, and that sort of thing. Another job for genetic counselors is to, if it's brought to their attention, is adults getting cancers maybe at a very young age. Like my former female friend of mine had a friend, this is 20 years ago, woman who got breast cancer at age 27. This is like, whoa, like this doesn't happen, but it did. So that's often a clue, has to be investigated further by genetic counseling and genetic typing and so forth. A common cancer experienced at a very young age, outside the, the plus and minus of where the 90% of the cases are. The other thing would be a number of people in a family who, as adults, will use breast cancer again. My grandmother on one side got breast cancer, my grandma on the other side had breast cancer. My mom had breast cancer. I'm a woman now 40 years old, and I think I have breast cancer. So there's something genetic there. Now, we sometimes use the word sporadic, which I never understood why that was used, for the cancers that we don't know why they're called, like sporadic. It's going to happen. So I think there's a reason and a rhyme. But when there's something odd within a family, then genetic counseling can be very helpful, because you want to know up front, okay, you're getting your breast cancer at a young age, you have a younger sister, we need to know what's going to happen with her and how we can maybe prevent something or have it happen, prevent it or catch it early. Okay. The BRCA1 and BRCA2 genes, of course, we always, when we have abbreviations, we like to make a word out of it and pronounce it. Breast cancer 1, breast cancer 2 genes. If you have that gene, it's really a set of genes, 50% or more lifetime risk of breast cancer. Now, I remember Dr. Cole talking about this. This was years ago, and maybe things change in society along the way. Some women, he said, with this knowledge, say, take my breasts off, because I don't want to worry about 50% is pretty high. Like, rather than if I have no breast tissue, I'm not going to get breast cancer, which I think is true. I don't know if that's done or how often that's done. Ovarian cancer is another one related to breast. Breast cancer and ovarian cancer, again, I know how to screen for breast cancer. Ovarian cancer, maybe, but I don't know what causes either one. So we wonder if genetics are going to help us out more there. Okay, prostate cancer. That's another one. Again, there's kind of a parity between breast and prostate. The numbers of new cases are kind of similar in the United States. The number of deaths kind of similar. We're talking about female breast cancer. Actually, 1% of breast cancers are among men, but as a public health issue, prostate and female breast. Genetic causes may be the answer there, because I'm clueless on genetic causes, on environmental causes. Colorectal cancer, hereditary familial polyposis, that I do have a colonoscopy, I'll just confess, every, 7 years, something like that. And one thing they look for is polyps. And colorectal cancer can be, if there's an early cancer, can be spliced out, and we're good. Or they now use the term interception, like in the football term. If there's a polyp that is not yet cancer, my first example, if we see a small cancer, we cut it out. Interception means it's a polyp, and maybe of the type that can become cancer, so let's cut that out. So that's a cancer, kind of a primary cancer move, in addition to the secondary, which is screening to find early cancers. Then there's the Lynch syndrome, again, genetics. Now, common childhood cancers. If you remember from a few minutes ago, the cancers I talked about for several slides, I talked about lung cancer, breast cancer, cervical cancer. What's on this list? This list is like a whole new list. So if you want to become a cancer epidemiologist, and I think you probably should, one thing fairly early on is you might want to decide, do I want to study childhood cancers or adult cancers? You don't see here on this list lung cancer, breast cancer, prostate cancer, colorectal cancer. I mean, they can happen, but these are the common cancers among children. So it's a whole new thing, okay? So again, the environmental, again, the focus is not on an environment. Maybe there's something we're missing. The inherited mutations, and I know a couple of Dr. Kim Whalen in Children's of Alabama Hospital. She's head of the late effects clinic I mentioned. If you have a child who has cancer, treated successfully, so it seems, it's not scot-free, rest of your life, have a good time. It's come back for annual exams or maybe more frequently. And they deal with genetic counselors there in Children's of Alabama. The inherited mutations, sometimes, but sometimes you don't have the data, or you can't, why did this child get this cancer? I didn't have cancer, my wife didn't, no one in our family did. Like, hello? The explanation that Kim had is, I guess, kind of a step pretty much like we don't know. Just the nature isn't perfect, that these are acquired mutations. DNA copying errors. Now, I'm not going to defend that, but the idea there is evidently in childhood cancer is it's not easily traceable to your family tree and say, aha, I know why your newborn has this cancer because of this previous cancer in the family. Okay, can cancer be controlled? Yes, primary prevention is the ideal. Identify environmental causes. We need more genetic research. Secondary prevention, again, there's a lot of, just I'd say in the last 10 years, a lot of improvements on cancer screening, who to screen, how often to screen, and so forth. Tertiary prevention, again, is kind of after the fact. There was a cancer diagnosed, a case. We need to do the best we can in matching each case up to some sort of treatment. Health behavior and health policy, two of our academic departments here, vital in cancer control. So, and both apply to, I guess, all phases, primary, secondary, tertiary. The idea of educating people about avoiding cancer, cancer screening, aftercare from diagnosis, and policy people, again, for things like no smoking in restaurants, other policies about and things like health insurance, being able to cover cancer-related treatment. Okay. And cancer.org, again, is from the ACS. Epi 713 I taught in the, what was that? That was in the fall, and we'll put it on the calendar every 2 years. I don't know, sometimes it doesn't fill. We usually have somewhere between 6 and 20 students, varies, okay? Now, a few minutes left. Do I quit at like 10 before or 5 before? 5 before, okay. So, the following slides are from the American Cancer Society, cancer.org, and the ACS, again, is not a branch of the federal government, if you don't know about that. That's the NCI, National Cancer Institute, which is part of the National Institutes of Health, which is federal. American Cancer Society is a 501c3. It's a company or a business, and they do at least two things. Help individual people who have cancer and have limited resources to get once a week to their cancer treatment, like transportation. Sometimes other help can be rendered for people in need. The other thing is they do fund research. They don't fund as much research and nearly as many dollars as the National Cancer Institute, but they do fund some cancer control research, mainly if you have a research project in mind of controlling cancer in a community type of thing. They're probably not going to fund, I don't think, genetic research, even if you're a geneticist, they're not going to probably fund your study. They want to fund like an applied research type of study, okay? So let's look, we'll go into 5 of and then quit. New cancer cases in 20, these are about the same numbers. You can see again the parity, kind of the same, prostate and breast, number 1 and number 1 in incidence. Lung and bronchus, number 2, colon and rectum, number 3, number 3. And on down the list. Risk. You remember from epidemiology, risk estimates are based on so-called cumulative incidence data. So if I have cumulative incidence data, it means I have numbers, population I already studied, and then I say, you're just like the people I studied, and you want to know your risk of breast cancer. I think it's 1 in 6, whatever, because of your age and probably other factors. So risk in the U.S., and it varies like who you are and lots of other things, but big picture, you can see the risks for males. The most common, so I have not had cancer diagnosed to date, knowing nothing more about me, well, that I don't smoke. So if I'm going to get cancer, my highest, if you're a betting man or a betting woman, is prostate cancer, 1 in 8. Females, breast, again, instead of prostate. That's the 1 in 8 there, okay? And lung and bronchus is going to vary a lot whether you're a smoker or not. Trends in cancer rates per 100,000. Male incidence, that big blip around 1990. A story for another day. That's when prostate cancer screening, the PSA test, started to be in vogue, and every guy and his brother were diagnosed with prostate cancer based on the PSA number. It's a numerical readout, like 0 to 100. I don't think it goes that high. PSA reading, it's good if it's a 0, 1, 2, 3. The idea there was a lot of the so-called cases were histologic only, except the data were already mounted. So there's a step back or two on the PSA testing, and what do you do if a man has a positive PSA test. The male and female incidence is the weighted average of the 2 other lines. It is not for people who are male and female. It was a joke. Okay. There is the prostate cancer bad actor there. Incidence. Females, again, breast, go back 1. Prostate cancer got up to, again, with that proviso, like 225 per 100,000. Breast cancer never got that high. And of course, it's too high still. That's around 140. 5-year survival. That has improved a great deal. 5-year survival was originally measured, I am told, by, or was something of interest to hospitals. So if there were competing hospitals in Birmingham or some other location, and each of them had a cancer program, like come to my hospital if you got cancer, one thing they measured and then would publicize if it turned out well. We have data from 5 years ago, and X% of our people treated 5 years ago were still alive, and then the hospital down the street would have their percentage. So 70%, it's going up. So these, again, 5-year survival is this the typical, I don't know if you want to call it cured, but something pretty close. Relative survival, still a racial difference here. It's measured simply black and white, kind of an outdated, I think, way. If you want to look at race or ethnicity or whatever, the black and white is probably not the best, but there it is. 5-year survival, again, does vary. Okay, new cancer deaths. So the list is kind of the same, except number 1, the first and second are flipped. Prostate and breast were number 1 and number 1 in incidence. They're number 2 and number 2 in mortality. Number 1 in mortality is lung and bronchus. Okay, and the other sites are fairly consistent. Trends in cancer death rates going down. So again, the death rate's going to go down when we have a higher and higher percentage. Now this is among people, who have it diagnosed. As time goes on and there's earlier and earlier diagnosis among more and more people, then the cure rates are higher and higher, so the death rate should be going down, which it is. I don't like this slide, so I skipped it. Okay, trends in cancer death rates among males, among females. Uterine corpus, very little. By race and ethnicity, and again, there is or has been research, like why should this be? Why should it be different between one race or ethnicity and another? And there's difference there. Okay, for children, again, we're just about done. So notice this is not per 100,000, this is per million. So the cancer rates among children are a lot lower numerically than among adults. The incidence is much lower compared to adult cancer. The mortality rate is much lower compared to adult cancer. Survival is much better compared to adult cancer. So you could say if you're going to get cancer sometime in your life, I don't think you have a choice really. Get it as a child, but the advance they made as compared to older data on children seemed ridiculous to me to have a data set where the newborns, the 0-year-olds, and the 19-year-olds were in the same category as children. So now more modern presentations of data have, by whatever names they're going to do, children and adolescents or somehow broken down age. 5-year survival, again, pretty good. Late effects, though, were okay. We're about out of time, so that was the first of the two ACS slides. This slideshow, and again, we'll keep it uploaded here for anyone. Another ACS slideshow, I think it's, yeah, there's about 40 or 45 slides. These slides, we'll quickly just do thumb through. They're more on prevalence of exposures, cigarette, like state to state. Alabama comes out not so well in many of these. That's something, if you're interested, to look at. We have time for one or two questions.